Is Lisa here? It's good. So it's a real honor to be invited to speak. I want to thank you for the invitation. And it's been very impressive to hear about this organization's work to not only improve service delivery in Eastern Europe, but also to support the careers of young faculty and to develop the future leaders of psychiatry, psychology, social work in Eastern Europe. So it's really a pleasure and an honor, and I want to thank you for inviting us. So Lisa, my wife, and I are going to spend the next 40 minutes just giving a very brief overview of the treatment of schizophrenia, sort of from a U.S. perspective. So I'll speak very briefly in 20 minutes, and I realize the challenge for all of you is just to provide basic services, for people in Eastern Europe. This perspective is a little bit different in that in just 20 minutes, I can't really cover, I think, the extent of basic treatment, but rather I just want to highlight some of the issues that we are now concerned about, in the U.S. and sort of in psychiatry in general, in terms of provision or improving psychiatric or pharmacological biological treatment of people with schizophrenia. And so I'll give a very quick sort of background and then want to talk about some of the real challenges, the areas that are particularly problematic in terms of providing care for people with schizophrenia. So as you all know, the first antipsychotic, clozapine, or brand name Thorazine in the U.S., was synthesized in France in 1950. Delaney Denneker did really pioneering work to study this drug in psychiatric patients, but it was initially developed as an antihistamine for surgical patients. It was just found to have this dramatic, calming, tranquilizing effect. Patients remain awake and alert, but seem to be relatively unconcerned with surgery. So this is a study in the U.S. where chlorpromazine was approved in 1953, the first several years of use in New York State. And this just shows the dramatic reduction in the use of restraints in hospitalized patients in state hospitals in the U.S. So chlorpromazine and the subsequent antipsychotics dramatically changed the care of people, and in this case was a major contributor to the deinstitutionalization effort in the United States starting in the 1960s, and it really has transformed the care of people with the illness. Obviously, this is only a small piece of allowing people to live out in the community, but for many people, a necessary piece. So now looking back after 60 years of these drugs, in terms of the efficacy, there are many different ways to measure it, but in terms of the percentage of people who will benefit or show response to these drugs versus placebo, the number needed to treat is a measure that can be used across drugs, across all of medicine. And in general, these drugs for acute psychosis are moderately effective and clearly effective. At least twice as many people will respond to these drugs as to placebo. And in preventing relapse, they're even more effective, so that they have a large effect size. So these measures, number needed to treat of 6 and 3, rank these drugs among the most effective treatments in all of medicine. So antipsychotics are clearly effective, not effective for everyone, and some people, probably 10 to 20% of people, will probably recover without them. But nevertheless, these are very effective medicines compared to other treatments for people with chronic medical illnesses. But one of the many problems with these drugs is, although they are quite effective for many people, from the perspective of patients, it's not always that obvious that these are drugs that people would want to take. And this was an interesting study, cross-sectional study for the path analysis, looking at the perspective of patients treated with antipsychotic drugs, and the relationship of adherence with these medicines in relation to their sense of quality of life. And whereas family members and clinicians tend to see marked improvement in quality of life from their perspective, for patients, as you can see here, okay, oops. Oh, here we go. Okay. One second. From a patient's perspective, with increasing compliance, as they become fully adherent, psychotic symptoms, as you would expect, decrease, but the side effects increase. And the side effects tend to have a larger negative effect on the patient's perception of quality of life compared to the improvement in quality of life with psychotic symptoms. So there's no net effect on quality of life from many patients' perspective of taking these medications. So we can see these medicines as being a great therapeutic benefit. We see psychosis improving, but the problem for shared decision making and the major task for clinicians and for care delivery services is working with patients to improve adherence and to overcome this problem in terms of the balance between side effects and perception of efficacy. So when I talk tomorrow about first episode psychosis, I'll talk more about clinical management and helping to improve adherence. So since barbitazine, there have been introduction of many other antipsychotics. This is just a list of second-generation agents available in the United States. There's the first group, starting with risperidone, which added a serotonin blockade, serotonin 5-HT2, which improves neurologic side effects and reduces prolactin. Clozapine represents a drug that very loosely binds D2 receptors, which is another way to prevent the neurologic side effects. And then more recently, there's been the introduction of the partial agonists. I'll talk a little bit more about them. And then the one drug that really stands out, as you all know, is Clozapine. The mechanism is still not known 30 years after introduction of Clozapine, but Clozapine being far more effective. In the U.S., the percentage of patients treated with Clozapine is probably one of the most important metrics for measuring quality of care. That clearly not all patients will want to be treated with Clozapine, not well tolerated, but we really believe that all patients who continue to have distressing or disabling psychotic symptoms despite adequate treatment with other agents deserve the opportunity to at least consider Clozapine treatment. It's estimated probably that at least 20% of patients would benefit from Clozapine, but in the U.S. at least, it's underutilized in many systems. And it's very important to appreciate that not only is Clozapine more effective for refractory psychotic symptoms, it markedly reduces relapse, it stabilizes mood, it's highly effective for hostility, aggression, and suicide. We're just submitting a large multi-center trial grant proposal to study Clozapine for aggression and violence within the community. And then it has a whole host of other probable effects in terms of polydipsia and hyponatremia. People who drink too much fluids and lower their sodium may improve the use of substances also. So with this large increase in numbers of antipsychotic drugs over the last 20 years, unfortunately, Clozapine is really the only drug that stands out in terms of having greater efficacy. Amisulpride probably does, and possibly olanzapine, but the rest of the drugs are pretty much comparable in terms of efficacy. So we've not made much progress really in the last 20 years in terms of developing more effective drugs. Fortunately, with this increasing number of drugs, the side effects vary between drugs, and so it's often possible to find a drug that a person will tolerate if they're particularly bothered by one side effect. And the side effect that's most problematic with this group is weight gain with associated diabetes and elevation of cholesterol or triglycerides. And this is just an example of showing that the drugs do in fact vary quite a bit in terms of the tendency for weight gain, and some of the newer drugs actually are relatively benign in terms of weight gain. So it is although we don't have many options in terms of drugs for people who fail in terms of the psychotic response, we do have enough drugs available that we can usually find a drug that is adequately tolerated. So there are a number of issues now that the field is I think, very much interested in terms of these drugs. I've just listed a few of them here. One is the fairly consistent evidence that the longer that a person remains psychotic, the worse the outcome. So the greater the delay in treatment. And in most studies, treatment it consists of starting antipsychotic, although it's not clear that the starting of an antipsychotic is necessary in terms of defining the end of untreated duration of untreated psychosis. But this is a fairly consistent finding, potentially very important, because why does psychosis seem to potentially injure the brain if this in fact is a causal relationship? And are there other ways that we could prevent this injury to the brain from occurring if that's real? And so in my talk tomorrow, I'll talk a lot more about our own research in the first episode of Psychosis, trying to understand this. There's also evidence, which I'll discuss tomorrow, that psychosis during relapse may also worsen the subsequent course. So again, question, is psychosis in some way toxic to the brain? How do we understand that, and can we prevent that effect? But on the other side, there's suggestive evidence that antipsychotics may be related to gray matter loss. There's concern about are these drugs neurotoxic, or could they in some way injure the brain in some patients? And I'll say more about that tomorrow as well. But these are some of the current issues that are very fundamental in terms of can we protect the brain from psychosis, and are our treatments themselves in some cases potentially problematic. So, so we've not made much progress in terms of developing more effective treatments, but we do have sort of a greater range of potential treatments. And one of the areas where new drugs are emerging are in the area of partial agonists. Again, these are drugs that bind to the dopamine D2 receptor, most with high affinity, so they tightly bind. But these drugs, unlike dopamine, that activates these receptors 100%, causing the intracellular pathways to be activated. And unlike a traditional antipsychotic, which causes no activation of the receptor, these drugs cause varying activation. And so as we develop more partial agonists, it's possible to sort of target the degree of dopamine reduction, and it may be possible that people vary in the degree to which their dopamine systems need to be downregulated. The first of these, bifenthronox, activated 84% and was not effective as an antipsychotic. Aripiprazole and now cariprazine seem to be highly effective with 61%. And a newer agent, brexpiprazole, activates 43%. So in other words, it's a little more of a down-regulation compared to aripiprazole. Cariprazine is also acts at D3 rather than D2, and so there's some interest now in terms of whether D3 receptors may be more involved in terms of motivation and negative symptoms. So this, although this is, I think, sort of a modest advance, nevertheless, it does represent an emerging area of drug development, and we just need to have head-to-head comparisons between these drugs. But there's some indication that these drugs may be a little bit more effective for negative symptoms. I won't talk about long-acting injectables, because I know the next lecture and the lecture tomorrow involve that. But this is another area that the pharmaceutical industry has invested a lot in terms of developing long-acting injectables that have varying durations or longer intervals between injections. And for some patients, this may be quite useful. It's been very difficult to show benefit in randomized controlled trials between long-acting and oral agents. And there's a lot of debate why that's true, and it just may be that patients who participate in randomized controlled trials may tend to be more adherent than some patients in the community who might benefit more clearly from these drugs. So so we have drugs that are effective reasonably effective for most patients. The problem of side effects and adherence continues to be a big problem. Where we've entirely failed has been developing drugs for negative symptoms, apathy, social withdrawal, and developing drugs to improve cognitive performance in the subgroup of patients who develop cognitive deficits with attention and memory and higher executive functions. So despite a major initiative about 10 years ago by the National Institute of Mental Health in the US, which was working with the FDA, the Federal Food and Drug Administration, and with academic centers throughout the US, it was funding work groups to develop strategy for developing cognitive enhancing agents. Industry invested in probably about 20 drugs aimed at cognitive enhancement in people with schizophrenia. And so far, all of them have failed. It's been very disappointing. And clearly, improving cognition is much more complicated than anyone imagined just 10 to 15 years ago. And one of the lessons has been that animal models seem to be poorly predictive of the effects of these drugs in humans with these illnesses. So this has been very disappointing. Negative symptoms, there's been a little more success, but again, very modest. Among the drugs that in meta-analyses seem to have some benefit for negative symptoms have been antidepressants, selective serotonin reuptake inhibitors. Folate, now in about 5 trials, appears to have modest benefit, and it may be possible to predict by genetic testing who will benefit from folate. And then finally, as I said, the partial agonist, aripiprazole and piperazine, have shown some benefit for negative symptoms compared to the other drugs. But all of these effects are modest, considering that cognitive deficits and negative symptoms are probably the largest contributors to disability. This is very disappointing that we've not made more progress in this area. So given these shortcomings, that we don't really have drugs for negative symptoms or cognition, that our drugs for psychosis are really limited to the large collection in Clozapine, there's been increasing interest in alternative sort of biological approaches. And I'm just going to mention 3 topics that are of particular interest. So the first is exercise and diet. And by exercise, I mean both cognitive exercise, so cognitive remediation, but also physical exercise and diet. There's a growing literature showing that obesity, diabetes, metabolic syndrome really adversely affects the brain, and particularly the hippocampus. You can show in animal models and in humans that with obesity, with metabolic syndrome, cognitive performance declines. You see the hippocampus begins to atrophy. And increasingly, studies in people with schizophrenia with diet and exercise are showing gains in terms of cognitive functioning. So a lot of interest now in sort of the brain health, and one way to achieve that is through diet and exercise, both cognitive exercise and physical exercise. Also, a lot of concern now about the environment in many ways. One is from animal studies show that exposure to an enriched environment, so in the case of a rodent, say a cage with a lot of stimulation, dramatically increases the size of the hippocampus, cognitive functioning, and some suggestion that that may be true in our patients also, the importance of cognitive stimulation through cognitive remediation or through just activities that stimulate a person seem to improve the cognitive function. But also the concern about toxins in the environment. And I was just going to mention air pollution, which is recently emerging as a major factor in terms of cognitive functioning. We've just finished an analysis. We're doing studies of first episode patients in China and in the US and various cities, and looking at hippocampal volume, which is much smaller in schizophrenia, and we show the reduction in hippocampal volume correlates with negative symptoms. But we found in our study that the average air pollution in the city highly predicted the hippocampal volume decrease in our patients, and that's been shown in larger populations as well. So air pollution, among other toxins, seems to be a contributor to cognitive deficits, and people with schizophrenia may be more vulnerable to pollutants and to other forms of, say, inflammation or stress. And want to finish with sleep. And I know there's going to be a talk later about the digitalized evaluations of sleep. So sleep is also emerging as being critically important in terms of brain function and brain health. And some sleep markers like sleep spindles are dramatically abnormal in schizophrenia, may be important biomarkers. But among these sleep problems, which are very common in schizophrenia, obstructive sleep apnea is really important because our drugs, which cause weight gain, cause sleep apnea at fairly high rates. And there's a growing literature now on sleep apnea being associated with Alzheimer's disease, cognitive deficits, can really adversely affect performance in people, both with schizophrenia but in the general population. Because rates are so high in people with schizophrenia, particularly treated with these drugs that cause weight gain, it's important to be aware of that to try to prevent it, and then CPAP, treatments can probably relieve that. And then the final area of interest, which is rapidly emerging, is cannabidiol. So cannabidiol being a component of marijuana. And there's some evidence that THC, which is the component of marijuana that causes people to be high, may worsen the course of schizophrenia. Some debate whether THC can actually cause schizophrenia or cause it to appear earlier. But cannabidiol, on the other hand, seems to be protective of the brain. It may stimulate or increase levels of a substance called anandamide, which some people believe may be the brain's protection against stress and have antipsychotic effects. So there have been 2 trials now, most recently this placebo-controlled add-on trial of cannabidiol in schizophrenia, suggesting that cannabidiol may have efficacy for psychotic symptoms that do not respond. So there's a lot of interest across the psychiatric spectrum, PTSD, depression, substance abuse in terms of cannabidiol and the endocannabinoid system. So let me stop here. I just mentioned in terms of the future direction and what we're all aiming for in terms of drug development. First is, as we've talked about already today, early intervention, finding benign drugs more benign than antipsychotics, which might prevent onset of psychosis. As I'll talk about tomorrow, we do see progression of the illness. In our work, we find hippocampal atrophy, which is associated with poor outcomes. Can we prevent progression of the illness with benign treatments? And importantly, identifying those people who need to continue on these medications, but also identify those people who may not need to continue on the medicines. How do we get them off of antipsychotics and prevent relapse? And then in terms of new treatments, the hope is we can develop drugs that improve plasticity, improve people's ability to learn and to benefit from psychosocial treatments, and that's an area my group's been working in. And ultimately to develop precision medicine where we have biomarkers, maybe genetic, maybe neuroimaging that allow us to match treatments to individual patients. And the suggestion is there's probably a huge number of genetic variants which potentially might benefit by selective targeting with different agents. So now let me turn this over to Lisa.
Good afternoon, everybody. We have great conversations over breakfast, lunch, and dinner. So I wanted to start out with my disclosure slide. I don't have any connections with industry to disclose, but I do have an important disclosure, which is that I have a family member with schizophrenia, and this is a photograph of my siblings and me. This was quite a number of years ago. I'm the cute little girl in blue. And one of my brothers, developed schizophrenia He developed schizophrenia when he was a medical student, actually, at a fairly prestigious medical school in the United States. And he failed out, having been an A+ student in college. He failed out of his first year of medical school, and they let him come back, and he was able, actually, while he was, I think, highly symptomatic, to finish the first year, but then failed the second year and was sent home without any real information or given to the family, to us. And now, 40 years later, he actually is one of the few people with schizophrenia in the United States that's hospitalized in a long-term facility in New York State, unfortunately. So I wanted to share that with you because I think it's important, given the conversation that we had this morning about families and service users and advocacy, and I just wanted to make a few comments about that before I launch into the psychosocial discussion, and to acknowledge and agree with what was said this morning about the challenges of engaging and empowering the family and user community. It is hard, and it is a process. And I wanted to make the point that it's not disconnected from the general sort of process of the people and consumers and families being empowered in all walks of life, of almost like the do-it-yourself existence. And so I think in the United States, for sure, the empowerment of people and families in mental health is related to the empowerment in general medicine and empowerment in all political spectrums. And so it's really part of the whole community engagement. That being said, it is possible to do, and you can be a part of it. We can start, I believe, by our own practices, and we can start as clinicians within our own practice, and I'll talk about that a bit, and we can also start as researchers. I mean, I'm a clinician, I'm a researcher, I'm a family member. And I speak out, and I conduct research, as you'll see, and I work on it so that, in some ways, to be an example. At this point, if they don't like me, I don't care. Or if they're going to hold it against me, I don't care. I'm going to try to let my work represent me. So I think, again, I'm going to talk a little bit about this. I've chosen to highlight some of the interventions that individual practitioners can do in their own offices. We don't need to change the whole mental health system necessarily to do some of this empowering work and to bring in the voices of stakeholders. So I've taken a few of my precious minutes. Again, I actually want to thank Don because he actually began the discussion of the inclusion of psychosocial interventions. He talked about enriched environments. He talked about cognitive remediation, and I want to make the point that if we think broadly about psychosocial, it really is extremely, it includes a lot of things. And so if we're talking about quality of care, that's kind of my focus. Again, the psychosocial and the psychopharmacology. What is quality of care? And I think we began to talk about it this morning. It's the degree to which health services for individuals and families and populations increase the likelihood of desired outcomes and are consistent with current professional knowledge. And so in my work, there's been a lot of focus on integrating this notion of current professional knowledge and evidence-based practices into care. And so I had really the privilege of working, this was my early contact with Howard Goldman in something called the Schizophrenia Port, Schizophrenia Patient Outcomes Research Team. And the ports were really the early efforts of the 90s and late 80s in the United States to identify evidence-based practices. And it sort of, I kind of grew up on this notion of evidence-based practices, but implicit in that is this notion that we didn't, now we think of evidence-based practices roll off the tongue, but there was, it's not that new, it's not that old, it is a relatively new phenomenon, that this notion of actually trying to apply evidence. And so we, at the University of Maryland, with the leadership of Howard Goldman and Tony Lehman and Don Steinwachs, had the first, what was called port, that was focused on mental illness. And it's interesting that why did the ports come to be? Why was this, how did the primacy of evidence-based practices evolve? Well, the first port was focused on back pain. And it was kind of motivated by the idea that when certain health services researchers looked at what interventions people got for back pain, it wasn't determined by evidence, it was determined by where they lived and what the common practice was. So that sort of was the impetus to say, people need to get services not based on where they live and what the favorite intervention of the doctor there happens to be, but rather based on science. And so the ports were, the port projects were focused on identifying those practices and specifying and articulating them. And this was the first article that came out in the Schizophrenia Bulletin on evidence-based practices for schizophrenia. And that first port project led to a second, and that second led to a third. And this is the publication from the most recent port review of evidence-based practices in schizophrenia. And this one was published in 2010, and I led the psychosocial component of the port, of this third port. And I will say that there's not that, I'm going to report on this, but there's not that much new since then. Sort of like what Don was saying, that, we haven't had too much in the way of breakthroughs. So I think it's sufficient to rely on the 2010 work. So what did we try to do with the schizophrenia port? We recommended treatments supported by substantial scientific evidence, with expert opinion playing only a limited role, and we didn't try to address all situations. We were silent on treatments lacking empirical support. So if there was no evidence-based practice in a particular area or for a particular problem, we said nothing. Okay. And I want to make the point that shared decision-making around all treatment choices is assumed. And I'm interested in the fact that here, this notion of it's very, very hard, it is hard to do shared decision-making. But none of these treatments are really for everybody in every situation. So we must have some process for identifying, who should get what. Even with a specific illness. In Don's discussion of medications, we have all these medication treatments that have the same effectiveness but have different side effects. So how do you choose? You have to, I would put forward that it's imperative that we bring the patient into that discussion and that we can do that relatively easily in the privacy of the consulting room. Okay. So, again, the latest research shows that we really should do something with all this research. Okay, so here is a summary of the treatment recommendations from the last patient outcomes research team or PORT project. And what I want you to see here, did I get this to work? Well, oh great, okay. So these are the areas or the treatments that were recommended for which there is substantial evidence that they're effective for people with schizophrenia. Assertive community treatment, supportive employment, etc. And if any of you guys want these slides, you can just send me an email. I'm happy to do that. These are treatments for which, at that time, there was insufficient evidence to support a treatment recommendation. And this is a combined psychopharm and psychosocial treatment recommendation. Okay, so I want to make the point here that actually at the time of the first report and at the time of the most recent set of recommendations, even in the United States, for the most part, very few patients receive treatment consistent with these recommendations. So it is a challenge globally, I believe, to really deliver evidence-based treatment to people with schizophrenia. So what I want you to see, this is actually 3% for supported housing, 2% for supported employment. And so I again, to emphasize that this is a global challenge. Okay, so I wanted to just focus on, I think these are what, seven EBPs, just very, very briefly, 7 evidence-based practices. And first, assertive community treatment, which is a complex team-based model for people who have recurrent hospitalization or who are homeless. And is that the first evidence-based practice to try here? Probably not. It's extremely expensive. So we're going to move from that one. It's there. It will reduce hospitalization. It actually does reduce homelessness. What about supported employment? Another really powerful evidence-based practice. Again, is this the next one to start? I would suggest probably not, because it really does require a new workforce and kind of a rearranging the organization of care, even though it's extremely effective. And then psychosocial interventions for alcohol and substance abuse. And of course, we in the United States are facing an opioid crisis, as Howard mentioned this morning. This is also a challenging evidence-based practice to implement because it does require thinking, rearranging the structure of care, which is a big lift. It's a big lift. So that leaves us with 4 practices that I would put forward are very reasonable to implement because they can be implemented in sort of within a one-on-one framework in care. Again, if we can engage our practitioners, if we can teach, if we can motivate, if we can inspire, and if we can do the same for service recipients to get them demanding care that is evidence-based. We want to have a supply-side approach, which is from the practitioner, and we want to have a demand-side approach from the service recipients. Okay. So I'm going to spend a minute. You know what? I'm obsessed with family support and family psychoeducation for obvious reasons. And I will just say, in the United States, family psychoeducation, actually, and in the UK and Italy, there's research all over the world on family psychoeducation with very, very robust evidence that family psychoeducation reduces relapse rates and improves outcomes. But it's been very, very difficult to implement, in the United States, in part because what practitioners will say is, the patients won't give permission, the adult patients won't give permission to contact the families. Now, so what, and I always say, if someone asked me, Lisa, would you want your family involved in your mental health care? You know what I would say? I would say it depends. Because I would kind of want to set the terms. I'd say, this one, maybe my mother, but not for everything, my husband, my sibling. So we need to give the individual patient some ability to set the terms. And so we created an intervention that's called REORDER, or recovery-oriented decisions for relative support. And it has two goals. One is to promote the consumer recovery in sort of the more contemporary definition of the word, not cure recovery, but empowerment, hope, agency recovery, and also to optimize family involvement in care. And this intervention has two phases, and it's built around shared decision-making. And the first phase is the consumer phase, right? And the second phase is the family phase. And so we work with the consumer, and we say, or the service user, or the patient, and we say, what are your goals? Who is in your family? And then we say, how might your family's involvement in your mental health care help or hurt your achievement of those goals? And you can see here, these are these very basic exercises that anyone can do with a patient. These are the values I have, and how might family involvement hurt or help? And we do a decisional balance exercise. What are the benefits of family involvement? What are your concerns about family involvement? And it is through this process that the patient, him or herself, can begin to first know that they will be heard, and second, to implement the plan that they, in some sense, specify for family involvement. And what do you know? We studied this in a randomized controlled trial, and what you see here is that in the reorder condition, before the intervention, only 10% of the individuals had family involvement in their care, and after it was over 50%. In our control condition, which was a very good control condition, really great family clinicians who were available, but they were only available, there was not this, what I call, shared decision-making frame or prior before the family intervention was offered. And so I put forward to you that this really is an example, so simple, using motivational interviewing, education, and enhancement as a way to deliver an evidence-based practice by engaging the service user in the process of managing their care. All right. So, and I think this was worth spending a few minutes on, because in some sense this kind of an exercise can be repeated kind of prior to any of these evidence-based practices. Okay. So just to go through very briefly the other evidence-based approaches. So we have skills training. So as Don was talking about, the very, very considerable problem that individuals with schizophrenia have with socialization. Social skills training is, again, an evidence-based approach that has been proven to improve social skills and behaviors. Again, to improve social interactions, independent living, and other outcomes that have clear relevance to community functioning. It includes behaviorally based instruction, role modeling. We can all role model. You can all role model in this session. Rehearsal, corrective feedback, and positive reinforcement. And then, the next phase after sort of the in-session phase is developing procedures for ensuring that the practice that occurs in the office can be done, can be repeated in the community. But again, there are manuals and tools that are available online to learn this stuff. It's really not that hard. And I can imagine, developing, this can be done in schools, the curricula in schools can be modified, and even, clinicians can develop work groups, and there's a lot of different ways that this can be done without the huge machinery of a system. Again, I think probably most of you are familiar with cognitive behavioral therapy for people with schizophrenia. And once again, I think there are many, many tools online to learn how to do this. And I think there's no reason why a clinician, even a psychiatrist who's primarily doing prescribing, can't use and employ CBT, which is an evidence-based practice, in their office. And Don alluded to and mentioned the importance of weight management. And again, there's now very substantial and robust evidence for psychosocial approaches for weight management. Again, focused on nutritional counseling, caloric expenditure and portion control, behavioral self-management, regular weigh-ins, things like this. So I mean, this is the kind of thing that, we all do, and now has been proven to be useful for people with schizophrenia. And I want to end with a diagram that comes from implementation science. Implementation science is really the science of taking these interventions that have been developed in research settings, which we know are not the real world. I mean, most cases, they're more controlled. You have these randomized trials, but are those trials including the patients that I see in my practice? And so implementation science is saying, well, no, not really, they're not. Okay? So we need to have a method for adapting these evidence-based interventions that have been developed in research settings to the real world. And I would say, for the real world would be each of the countries that you all represent and in which you all practice and in which you all oversee or are concerned with implementation. And so now we have a science of adaptation, so that we're not just doing it haphazardly, but we're doing the adaptation systematically and recording and making sure that we think through, we don't miss anything in our adaptation process, right? So this is, there are many adaptation models out there now. This happens to be one that I like a lot, and I love just the notion of the Adaptome. This kind of little, you put your intervention in the Adaptome, and then it comes out the way you want it to come out. But so you can see here, you have the intervention, service setting adaptations, target audience adaptations, mode of delivery adaptations, cultural adaptations, core components adaptations. And so again, I think that, in the world of health services delivery, the challenge that you all are facing here is really not that different from the challenge that I face in deploying evidence-based practices in Harlem of New York City, or in Washington Heights, where there's a big Dominican population, or in rural New York. Okay, we're all facing very similar challenges, and now I think the field of implementation science is beginning to provide a roadmap for making these important and challenging adaptations. Thank you. So, sort of on the subject of tools, this is the website for my center, something called the Center for Practice Innovations, and my center is charged with supporting the delivery of evidence-based practices throughout New York State. And what we have on our website is we have a number of tools for practitioners and for service recipients. And So these little faces here, you see, are 2 and 3 minute videos that can be shown in a training session, or can be watched by patients wherever they are. We use them in sessions. We use them to train our practitioners, and we also use them in sessions. So you watch with your patient. You watch the video, and it can be inspiring, and it can create discussion. So I just thought I would play one of them. This is Ryan, and he's talking about work.
That's a civil right.
Let me see if I can get this to
Hi, my name is Ryan. I'm 34 years old. I work full-time as a civil rights advocate for individuals with mental health disabilities in a state psychiatric hospital. I recently graduated with a master's degree. I happen to drive a nice automobile. I'm single, enjoy dating, and I'm also in recovery from a form of schizophrenia. Today I'd like to talk to you about how I returned to school. This is a picture of me when I showed up on the first day of classes to have my student ID taken. Overweight, disheveled, poorly groomed, and the thing that strikes me most about this picture is in my eyes, I can feel what it was like back then. I can see the hopelessness, sort of despair, in the picture. I definitely wasn't happy. On many days, I sort of wished that life would just go away, that I were dead. It was too painful. One of my main fears was that I would never be able to work. This process of going to school is futile, being a person with major mental disorder, to actually go through this process of going back to school. But I made the decision that I was going to go and study what I wanted to study and pursue my own education, actually to pursue knowledge for knowledge's sake, despite the fact that I believed that I couldn't work. In the midst of that 7 years that I was in college, I was hospitalized at my most ill moment. I had teachers that were very supportive and allowed me to make up the work. And I was able to take incompletes for those semesters. The support of my family, friends, and my professors was enough when I was hospitalized to allow me to believe that that wasn't the end of the road. The stress of school never put me in the hospital. I'd say the stress of believing I couldn't achieve at school because I'm a person with a mental illness probably was more stressing to me than the stress of finals and final papers and things like that.
I'll just stop that. And I know he was speaking very quickly, but what he said was it wasn't the stress of school that put me in the hospital. It was the stress of believing that he could never really amount to anything because he had a mental illness. And that's just a very powerful statement. Thank you. If you want to explore the website, there's lots and lots of stories. There's stories from mothers, from parents, from other patients on everything from talking to your doctor, the importance of exercise. There's a lot of these 3-minute videos. Peer support. I'm going to speak personally. My very first job after my research fellowship was to be the doctor on an assertive community treatment team. This was in 1992. And we had 2 consumer advocates and a family outreach worker. This was very visionary, I think, at the time. Completely changed how I thought about care. Because I saw these 2 consumer advocates who were people with histories of mental illness and homelessness do things with our patients that none of the professionals could do in terms of engagement and inspiration and making a difference in people's lives. We were also, again, we were targeting homeless people. And the family outreach worker, the same thing. This was someone who had no professional training, but who herself, her husband had a serious mental illness and her son had a serious mental illness. And she knocked everybody over. She was amazing, both working with clients and families and in working with the professional staff. So I have, my own experience in it being extremely powerful and effective. Now, in terms of the research and in terms of what, is the research on peer involvement at the level of a court recommendation? Okay? I would say, even now we have a paper coming out in Psych Services which would be, no, it is not. Okay? In part because there are so many models and it keeps evolving. The whole work with peer support keeps developing. And so it's not like there's an evidence base where you can say, this model done this way for these people improves outcomes. But from my standpoint, I believe that overall there is enough evidence to say that we need to do it, we need to think about it, we need I think also just on the basis of principles, nothing about us without us, I think it's justified. I do think, though, that that field needs to, we do need to continue to conduct research so that we can do it better and we can sort of have the weight of rigorous research behind us.